Hello everyone, this is Dawn Sugg. I'm here today to present my literature review on fibromyalgia. The butterfly, it is one of the symbols for fibromyalgia. Some say that the butterfly represents a delicate creature that is able to withstand strong winds, yet others suggest it is a representation on how even the slightest touch can cause pain in patients faced with this disorder. Pictured here on this slide, you will see one of the showcased artworks by the artist Brooke Shaden, who has attempted to express the emotions of fibromyalgia through her artwork. Shaden herself battled with fibromyalgia for 14 years prior to depicting it in this form of art. She has created timeless pieces of artwork that speaks thousands of words, describing not only the pain and desperation that fibromyalgia patients deal with, but also the power and grace that develop through their journey. She describes this image seen here as a close-up of weakness and vulnerability. The picture in her series with the fibromyalgia butterflies coming out of the woman's chest, which represents power. And then finally you will see a picture of a woman being held up by the butterfly showing acceptance. Shaden states that butterflies are an incredible universal symbol. They represent change, beauty, and grace. In a way, that is what people with pain go through, and especially pain that does not manifest in obvious ways. Throughout this presentation, you will see her artwork displayed on slides with this green ribbon, just as shown here. With written consent from the artist to include her artwork within this presentation has been obtained. All rights are reserved for the art and are not to be duplicated without the artist's consent. Patients with fibromyalgia face a daily struggle with pain, fatigue, restless sleep, as well as a lack of treatment options. Patients tell their stories of unacceptance and loneliness, fighting a battle that is difficult to explain in words. The struggle is in finding acceptance, validation, assurance, compassion, and an open-minded provider who understands the struggle they are faced with. However, the pain remains, and it is not adequately understood. Although over 5 million individuals are affected with fibromyalgia, there is not only limited resources for patients, but there is controversy that remains over the syndrome, even with the current evidence. Fibromyalgia syndrome is defined as a chronic condition causing pain, stiffness, tenderness of the muscle, tendons, and joints. Characterized with the mentioned symptoms, patients also experience extreme fatigue, increased anxiety, depression, and a variety of disturbance of bowel function. The unknown etiology of fibromyalgia and the lack of specific diagnostic tests create a challenge for the primary care provider. However, current studies have improved the understanding of pathophysiology, clinical diagnosis, and effective management of this condition, making it a disorder that can be appropriately managed by the primary care physician or provider. This presentation represents a review of literature that will discuss all of these tools for the primary care provider in efforts to bridge this gap of knowledge and build a better understanding for fibromyalgia. Here on the slide, you will see the objectives for this presentation, and they include, at the end, the student will be able to discuss the history and epidemiology of fibromyalgia, explain the pathophysiology, explain the autonomic dysfunction seen in fibromyalgia. They will be able to discuss common clinical symptoms and critical points within the H&P. We'll be able to identify risk factors, explain underlying psychological factors influencing fibromyalgia, and be able to appropriately create differential diagnosis. They will be able to identify appropriate diagnostic testing for fibromyalgia, identify importance of integrative treatment management plans, and identify treatment options including non-pharmacological and pharmacological treatments, as well as explain the steps of patient care, education, and follow-up. Fibromyalgia has been around for quite some time. It was described in the mid-9th century in Germany and labeled Muskelschwelle or muscle callus, and accompanied generalized body tenderness. Further clinical studies began in 1970s. Then, in the mid-1970s, Smith and Moldavsky coined the new term fibromyalgia and identified regions of extreme tenderness, the so-called tender points. It wasn't until the 1990s that the American College of Rheumatology developed a diagnostic criteria that was based upon those tender points. The most updated research reveals that fibromyalgia is the second most prevalent disease among the chronic pain disorders. Its prevalence has been estimated to be between 0.4% and 9.3% of the population in many countries around the world, with an overall mean of 2.7. Another study conducted in 2010 reported prevalence rates of 6.4% and 7.7% of that being male and 4.9% being men. As you can see, females have a higher rate of fibromyalgia. However, it still can affect males as well as children, which is termed juvenile fibromyalgia. African American women have the highest rates overall that of white women, and there is a noted increase in pain and tenderness with this disorder in patients with a decreased socioeconomic status, which can attribute to which may contribute to the racial differences. Economically, the burden has on healthcare costs is estimated to be $9 billion annually. Here is yet another picture of the art by Brooke Shaden. As it has been mentioned, pain with fibromyalgia can be devastating and demoralizing, creating a challenge for both the patient and provider. However, it remains a very common disease process. It can be described as a syndrome that causes dysregulation of sensory regulation or volume control. As patients have lower thresholds of pain, these thresholds can include stimuli to the head, noise, and strong odors. Another interesting aspect of fibromyalgia is that the painful tissues are not accompanied or associated with tissue inflammation. It is not accompanied by tissue damage or deformity and affects both sides of the patient's body. Although the exact etiology of fibromyalgia is unknown, there are some potential mechanisms that include the central pain modulation, neurotransmitters, simple adrenal hypothalamic pituitary adrenal systems, and peripheral muscular issues. The central pain modulation suggests that there is increased pain sensitivity, correlating with differing pain for different patients, as some patients experience more pain than others. This suggests that patients with fibromyalgia have lower pain thresholds, which could be attributed to lower levels of serotonin activity and dysregulations of the dopaminergic system. Still, there is evidence that supports increased hyperactivity of simple adrenal and hypothalamic pituitary adrenal systems. This means that these patients have hyperactivity in sympathetic activity, resulting in hyporeactivity responses to stress. Still, other evidence points to muscular abnormalities and peripheral pain dysregulation. Evidence shows abnormal muscle tissue biopsies have tissue hypoxia, reduced levels of adenosine triphosphate and phosphocreatine, metabolic abnormalities, as well as decreased blood flow, which is consistent with Raynaud syndrome, which often accompanies fibromyalgia. Yet, according to Cordone, Miguel, and Alcazar, there are specific biological, genetic, and environmental factors that contribute to neuronal activity in the central nervous system, abnormal metabolism of biogenetic amines, immunological disorders, and oxidative stress resulting in fibromyalgia. The authors proposed that this disorder develops due to poor stressor modulation changes in the specific neuroreceptor neurons, emotional trauma, chronic stress, and even a result from past infections. Their research proposes that new evidence reveals that the pathophysiology is due to genetic polymorphism, changes in the serotonergic system genotype 5-HTT, changes in cytokine homeostasis, mitochondrial dysfunction, increased levels of oxidative stress antibodies against serotonin, which create alterations in the metabolism, transport, and reuptake of serotonin and substance P. Some of the noted infections that are able to induce fibromyalgia are thought to be viruses like hepatitis C, HIV, Coxsackie B virus, parvovirus, and bacteria like Borrelia. Other potential triggering factors include physical traumas or trauma, vaccinations, and chemical substances. Other factors to consider when understanding the pathophysiology include genetic factors, the patient's underlying immune system, psychiatric components, and triggering factors like we just mentioned. Genetic studies suggest that there is a familial polygenic transmission that is related to an association to dysfunction of neurotransmitter serotonin or transporter gene expression. Thus, there is an increased incidence of fibromyalgia if patients have a first-degree relative who suffers from depression. Many studies suggest that there is an underlying serotonin autoantibodies that play a role in this condition. It is important to consider how fibromyalgia is linked to underlying autoimmune disorders. New investigation does show an association with antipolymer antibodies, the APAs. Although somewhat controversial, it could be used as a marker for disease, although it is not a marker for diagnosis. The psychiatric component of fibromyalgia is difficult to understand, as it may be associated with cause, but may be present prior to the disease. Thus, it is a question to which came first. However, it is important for providers to realize that patients with fibromyalgia have higher rates of psychiatric complaints compared to that of rheumatic diseases and can aid in differentials. Psychiatric complaints must be most associated with fibromyalgia include anxiety, somatization, dysthymia, panic disorders, post-traumatic stress, and overall depression. The depression these patients experience may escalate in situations in which these patients do not feel heard or feel that providers do not believe their symptoms, leading to guilt for their own perceptions. Common presentation. When understanding the pathophysiology and that of the HPA axis and its involvement, it's easy to understand how this is considered a stress-related disorder. Elevation in cortisol disrupts circadian rhythms. Knowing this, the primary care provider can better understand presenting symptoms of this disorder. Fibromyalgia most often presents in younger or middle-aged females. Red flags to consider include persistent widespread pain, stiffness, fatigue, disrupted, unrefreshing sleep, and cognitive difficulties, often accompanied by multiple other unexplained symptoms, anxiety, depression, functional impairment of daily living activities. Onset is often gradual and persists for more than 3 months, and complaints of pain will be widespread, can wax and wane depending on events, affects all 4 quadrants of the body, and most often affects the axial spine, usually the paraspinous, scapular, and trapezius muscles. In comparing the German Fibromyalgia Association and the National Fibromyalgia Association surveys for clinical presentation symptoms, there were slight differences. According to the national survey, complaints included morning stiffness, fatigue, non-restorative sleep, pain, forgetfulness, poor concentration, difficulty falling asleep, muscle spasms, anxiety, depression, headaches, anger, restless legs, and abdominal pain. And according to the German study, they found pain, fatigue, non-restorative sleep was the same, morning stiffness, poor concentration, lack of energy, low productivity, forgetfulness, irritability, weather sensitivity, feelings that the hands were swollen, dizziness, headaches, and visual disturbance were the most prevalent in their surveys. Patients often report having pain all over. They also report having irritable symptoms as well as other somatic symptoms including tinnitus or hair loss. So we reviewed a lot of the clinical presenting symptoms. Here are the 3 clinical symptoms to keep in mind: the pain, fatigue, and sleep disturbances, but also that there's varied somatic symptoms as well, including chronic cough, which hasn't been mentioned thus far in the presentation. Other red flags tip the clinician towards diagnosis of fibromyalgia is in knowing that these symptoms are present for greater than 3 months. And it's always important to listen to your patient's history for varying somatic complaints to poor concentration, swollen glands, chronic cough, tinnitus, coccygeal, and pelvic pain. When discussing the H&P with the patient, it's important to consider your old cards, of course, then also some questions that may guide differentials include, understanding if the presenting symptoms have been associated with a fever, asking the patient what is worse, the pain or the fatigue, trying to get an understanding of their life and if they're happy. Also, have they had weight changes, getting an understanding of some of the somatic symptoms. Also, we would want to know any recent injuries, physical trauma, motor vehicle accident, surgery, infections, exposure to a Lyme disease or any other infections that they're aware of, if they've had changes with any changes in their pain with any weather changes, and if there is a history of depression in their immediate family, of course. There is strong evidence that women suffering with this disorder have suffered from exposure to mental stress as well as physical stress loads throughout childhood and well into adulthood. Research into psychological dimension of fibromyalgia has been completed by a quantitative measures of using the Minnesota Multiphasic Psychological Inventory (MMPI) when comparing groups of patients with fibromyalgia. The results indicated that patients with fibromyalgia suffered from higher frequencies of psychological difficulties than any other group, thus resulting in higher levels of somatic anxiety. The results correlated to childhood patterns of high strain, low support, and overexposure to an adult world during the child's development, and leading to difficulties in and ability to protect oneself from high levels of stress and mental and physical stress, leading to a lack of self-protection in adulthood. Individuals with an unprotected self, or this lack of self-protection as adults, results in a lack of skills to handle inner life conflicts. They become unable to utilize signaling functions for evaluating their present life situations in order to determine if they are experiencing too much stress. In one specific study, 21 women who all met criteria for fibromyalgia were extensively interviewed by a clinical psychologist. The researchers found that these patients had an underlying pattern of lifelong exposure to mental and physical stress loads, including during childhood. They suggest that this resulted in women who posed patterns of self-destructiveness, lack of self-care, and somatic psychopathological alterations. Having an unprotected self results in compensating mechanisms that gradually degrade the mechanisms that control the intake of stress, resulting in further stress loads that can lead to pure exhaustion of compensating somatic mechanisms and potentially a reduction in cognitive function. Tentative interpretation includes that fibromyalgia may be fueled by reciprocal processes that must be considered when building a multidimensional care plan for patients. Clinical approach. One of the first aspects to consider when developing a clinical approach for this disorder is the fact that fibromyalgia patients may have spent years searching for answers with little results or support. Patients may have been searching extensively for a provider who will listen, validate symptoms, and provide guidance and support. On the other hand, providers may find it difficult to not only diagnose fibromyalgia, but as well provide adequate treatment. The management of fibromyalgia is challenging to both patients and providers as well as healthcare facilities. One qualitative study involving semi-structured interviews with 12 fibromyalgia patients and 9 healthcare professionals found that there are struggles from both patients' perspectives and from the healthcare provider. This gap must be bridged. According to this study, providers and systems need to find increased means to support each other, as well as provide awareness and a means for change. According to the American College of Rheumatology, diagnostic criteria is most widely accepted for diagnosing fibromyalgia. However, there are still limitations in value when attempting to rule out other diseases. There is no specific gold standard for clinical diagnosis for fibromyalgia. One of the difficulties is that symptoms differ and do not precisely align with standardized set of diagnostic criteria. However, it is not believed to be a diagnosis of exclusion, although some healthcare providers have labeled it as such. Because there is an absence of absolute, definitive diagnostic criteria with universal applicability, providers often settle upon the diagnosis following negative testing for other differentials. Rather than assuming a diagnosis for fibromyalgia, the clinical provider must always carefully consider multitude of potential differential diagnoses. When approaching developing these diagnoses for patients presenting with musculoskeletal systems, as mentioned earlier, and with symptoms greater than 3 months, along with cognitive impairments, the diagnosis of fibromyalgia should be one of the leading diagnoses, as cognitive impairment along with these musculoskeletal changes are key factors to fibromyalgia. Here you will see a list of differential diagnoses, including adrenal dysfunction, systemic lupus erythematosus, anemia, chronic fatigue syndrome, hypothyroidism, endocrine dysfunction, myopathy or drug-induced, Lyme disease, multiple sclerosis, rheumatoid disorders, vitamin and mineral deficiencies, electrolyte imbalances, psychiatric conditions such as PTSD, anxiety, and/or depression. There are several coexisting conditions of pain syndromes that may be present in this disorder, including that of rheumatoid arthritis. However, a diagnosis of RA alone may not fit a patient with just fibromyalgia, as RA does not fully account for the fatigue and sleep disturbances and cognitive changes that are seen in fibromyalgia. One study found that patients with fibromyalgia had a 72% decline in memory function compared to that of patients with rheumatoid arthritis memory decline of 25%. Showing cognitive impairments and changes are key to fibromyalgia. Another key aspect to the patient's diagnosis may be that of social or occupational functional impairment. Patients with fibromyalgia often do report social isolation, strained relationships, difficulty with activities of daily living, avoidance of physical activity, and even loss of employment. Due to the fact that fibromyalgia is caused by central amplification of peripheral sensory signals, resulting in amplification of perceived pain, and pathophysiology can be shared by other chronic functional pain syndromes, including lupus, chronic fatigue syndrome, and myofascial pain syndrome. Diagnostics for fibromyalgia. Although there is no definitive laboratory or diagnostic test specific for fibromyalgia, there are a compilation of diagnostic tools that can guide the primary care provider in diagnosis. According to the American College of Rheumatology, a combination of the 2010 diagnostic criteria of symptom scores and presence of chronic widespread pain with fatigue and sleep symptoms should be used to diagnose fibromyalgia. Level C evidence. Fibromyalgia diagnosis is often considered a diagnosis of exclusion for some providers. However, recent data is trending away from this methodology. Either way, all patients must be thoroughly evaluated for the presence of other disorders that could be the cause of symptoms before a diagnosis of fibromyalgia is made. An assessment of fibromyalgia is based on the criteria of classification of fibromyalgia by the ACR. The criterion involves a history of widespread pain, present for at least 3 months, pain in both sides of the body, above and below the waist, is considered widespread if all of the following are present. Pain in 11 out of the 18 tender point sites on digital palpation on both sides of the body, occiput, low cervical, trapezius, supraspinatus, second rib, lateral epicondyle, gluteal, radial trochanter, and knee. Tender point will only hurt specific to the area where there is direct pressure applied. The pressure applied is hard enough to cause the examiner's nail bed to blanch, or about 4 kilograms of pressure. A dolometer can be used to apply the exact amount of pressure. Although laboratory testing is not required for diagnosis for fibromyalgia, it aids in ruling out other disease processes such as anemia, electrolyte imbalances, and thyroid dysfunction, which is recommended. The ESR, CRP, and rheumatoid factor testings all have poor specificity and are only recommended to be ordered if there is a specific concern for connective tissue disorders. Fibromyalgia should be strongly suspected based on the provider's clinical findings. Formal symptom surveys or tender point examination can be performed to support diagnosis but not to exclude it. Regardless of the method used, establishing a diagnosis will help validate the patient's symptoms and aid in creating a more effective plan of care. It is not recommended to complete an ANA sub-serologies without a positive ANA and clinical suspicion of immune-mediated diseases, just as it is not recommended to do a Lyme disease test unless there has been a known exposure history and that correlates with the physical examination findings. Here is yet another pieces of art from Brooke Shaden. This image speaks to the excruciating pain and loneliness felt by some patients fighting fibromyalgia. As seen throughout this presentation, most oftentimes patients with this disorders have struggled with not only their symptoms but yet in finding support. Thus, the goal of therapy and treatment is focused on establishing an accurate diagnosis, providing patients with validation, reassurance, and support that they are needing. Next, treatment goals will be focused on patient education. There is evidence that once the diagnosis has been made and patients are appropriately supported, most all patients report improved satisfaction with health, fewer long-term symptoms, and reduction in healthcare utilization and cost. After a provider and patient relationship is established, treatment and laboratory testing for further conditions will naturally flow. Prioritization should be focused on different aspects of care that may be essential but should always include the patient's input. Gaining control of sleep may be one of those prioritizations. Once it is established, it can aid in relieving other symptoms. This may in fact mean that the provider may prescribe sleep hygiene techniques and limitation on different activities in order to promote sleep. It is important to be aware that there is no cure for fibromyalgia, but often can be managed with adequate symptom reduction and patient compliance, as well as life interventions. So here you can see the goals of treatment as well as some other framework for where we will go as far as our treatment plan. Overall, there is no single treatment modality that has been found to be universally effective for all fibromyalgia patients or for the varying symptoms in an individual patient. However, when patients are fully educated and armed with knowledge, including the nature of the disease, compliance and changes are more readily accepted and implemented. In the first patient encounter, it is important for primary care providers to give patients educational materials about fibromyalgia, including lists of resources, validate the patient's illness through empathetic listening and acknowledgement that the patient is indeed experiencing pain. It is also important for the primary care provider to uncover the patient's goals and any confounding factors that will reduce or inhibit recovery, including limitations to activity, even things such as pending litigations. When considering management options, it is important, of course, to consider each patient's particular circumstance, but also that fibromyalgia will require multidisciplinary approach, and therapeutic approaches should be given priority that do not focus on pharmaceutical drugs initially, but incorporates non-pharmaceuticals as initial treatments as able. Exercise and cognitive behavioral therapy are the treatments with the most evidence, and the net benefit, always representing a multi-module approach and reserving the use of drugs for episodes of intense pain or uncontrolled symptoms. It is the responsibility of the primary care provider to ensure that all management options are based from supporting evidence. However, just defining the evidence is not enough. As providers, we must develop and use tools for implementing and monitoring fibromyalgia evidence-based treatment options. The complexity of fibromyalgia requires a treatment approach that integrates an interdisciplinary strategy for optimal results. So initially, we need to be proactive and prepared. Know the patient, know your team, and know the community and resources. And then we will know the pharmacotherapy that is available, and you want to start low and go slow, titrate to effectiveness, and manage expectations, treat comorbid conditions, and implement non-pharmacological therapies. And you may need to write prescriptions for sleep hygiene, physical activity, self-management support, and cognitive behavioral therapies as well. Additionally, the second step is confirming the diagnosis. You educate the patient. You provide references, education material on the diagnosis, pathophysiology, treatment, and prognosis. You direct the patient to credible fibromyalgia information sources, including you must include the family and significant others in as appropriate. And then, of course, discuss expectations for treatment and set roles and responsibilities. We need to collaborate with the patient to prioritize individual goals for treatment. Identify 1 to 2 most important symptoms or function areas to focus on, and utilize assessment tools to aid in prioritization and document baseline statuses. So let's discuss some non-conventional treatment options. You can see them all here. And as presented, the first-line treatment options for fibromyalgia is actually the non-pharmaceutical interventions. This could include all noted here. Cognitive behavioral therapy has been utilized, as has been noted, to improve patients' perceived pain severity, sense of control, mastery over life circumstances, and improve functional abilities. One specific single-arm open study examined 23 patients treated with a 5 to 6 week group cognitive behavioral therapy and had reductions in depression and anxiety symptoms. Several treatment options are available, such as the CBT, including relaxation training, group therapy, biofeedback, which are all useful options. Exercise holds strong promise for patient outcomes with fibromyalgia and considered essential in care. Current literature greatly supports the efficacy of exercise. However, exercise programs are dependent on the patient ability, program, and intensity. Submaximal aerobic exercise, along with strengthening and stretching elements, is beneficial in reducing symptoms and hyperalgesic response. Moderate level intensity is needed in order to yield any benefit. It may be difficult for some patients, however, to implement exercise. In general, recommendations for exercise therapy includes starting at a low level where the patient can become engaged, incorporate a gradual increase, incorporate different types of exercise, reduction in exercise intensity duration, while maintaining the frequency of exercise if not tolerated. One important aspect to consider is diet interventions for these patients is the fact that fibromyalgia patients produce more damaging free radicals in their bodies and thus have a reduced antioxidant capacity. Normal cellular respiration produces free radicals leading to oxidative stress. An adequate antioxidant defense system helps to keep free radicals at bay. However, this isn't always possible for patients with fibromyalgia. Thus, a diet should focus on reducing free radicals and increasing the body's ability for creating antioxidants. However, there is mixed evidence on specific diet plans and guidance for patients, and perhaps the best option is the one patient individualized diet to that specific patient. Supplements also may be beneficial. Supplements that may be include vitamins like C and E and minerals like selenium, zinc, and magnesium, and phytochemicals are important for dietary antioxidants. Here you will see the first line recommended pharmaceuticals, including amitriptyline, duloxetine, milnacipran, and pregabalin, and cyclobenzaprine. However, initiating drug therapy for these patients should be reserved for specific situations in which they do not respond to non-pharmaceutical interventions, symptoms are intense, or they are experiencing eruptive pain. According to the Association of Scientific Medical Societies in Germany, even amitriptyline, the medicine that has widely been used, has significant secondary effects, and the methodological quality of the evidence that supports it is relatively low. Anti-epileptics and antidepressants may also pose the same risk. According to Garcia, Nicolas, and Hernandez, SNRIs like milnacipran are linked to controversy among different guidelines. The FDA has approved this drug for the use of fibromyalgia. However, it is specifically not granted for fibromyalgia in Europe. On the other hand, SNRIs such as fluoxetine has been widely used within the U.S. for beneficial effects for fibromyalgia, but not only on pain, but other symptoms like fatigue, depression, and anxiety. However, the Spanish guidelines prefer to avoid recommending them because of low-level evidence and controversy in the evidence found. Muscle relaxants have some lower level of quality and limitation efficacy, and opiates in current studies offer some relief, but use should be limited for short durations in time due to secondary effects of dependency. And here is a pharmaceutical's second line options: gabapentin, fluoxetine, paroxetine, tramadol, and others that have been found beneficial, including NSAIDs. We talked about the opiates, benzodiazepines, magnesium, DHEA, melatonin, guaifenesin, thyroxine, naltrexone, and some others, including vitamin D supplementation. In considering efficacy and consideration in these drug therapies, it is important to consider the evidence for and against it. One very recent systematic review of clinical practice guidelines reviewed 249 guidelines of which only 13 were found to be valid. And of the 13, 6 of them all had similarities. Specifically, 7 therapies appear in all guidelines, including aerobic exercise, cognitive behavioral therapy, amitriptyline, SSRIs and SNRIs, anticonvulsant drugs, and mild opioids. Amitriptyline, when used in short duration, is the drug therapy for which the evidence is most solid. However, it requires close patient monitoring and follow-up of any secondary effects. If amitriptyline fails to provide relief, there is interactions, the alternative agents include SNRIs, SSRIs, and anti-epileptic drugs, and also fluoxetine and paroxetine. And then finally, pregabalin are alternative agents, respectively. In their systematic review, the authors found mild opiates like that of tramadol had contradictory recommendations, although it is still recommended if all other options have been unsuccessful. Exercise programs are the treatment of choice. They have the highest level of evidence of efficacy, although it is still the area with the least recommendations. Psychology offers another activity that is based on solid evidence and has positive results. Cognitive behavioral therapy should be taken into account as part of the multiple interventional approach. This brings us to step 3 in our integrative care approach, and it's maintain focus on progress over time versus daily ups and downs. Patients can see ups and downs on a constant, but they need to look at the overall picture, and that's one part of the process that a primary care provider can provide. They continually evaluate on patient follow-up visits, on progress, the physical activity, self-management techniques, and then to evaluate medication efficacy and look for adverse effects. This is a dynamic process that's ever changing and requires changes in goals as well. Here is the patient empowered, and one of my favorite pictures of this presentation. This slide talks about patient education. Patients, and the purpose is to not just inform, but to empower the patients with fibromyalgia. They're armed with knowledge and validation and support. Patients are best equipped to deal with fibromyalgia and a world of pain. Patients should know that fibromyalgia is not a progressive disease, and with current intervention and support systems can be reduced. Here's just an example of some patient education and specifically how to discuss a diagnosis of fibromyalgia and just giving them the straight up facts, including some web-based information systems they can be connected with. And you can read in here, what is fibromyalgia. So you just talk about the evidence, what causes it. The exact causes of fibromyalgia is not fully understood. You're just giving them the truth, that what we know, evidence suggests that there are genetic and environmental factors that predispose individuals to the development of fibromyalgia. And can it be cured? It's similar to chronic conditions, and it cannot be cured, but symptoms can be controlled. Just reassuring them that their symptoms can be controlled, and new treatments are available, and no single treatment works for every person or for every symptom, and that it requires patients to be active participants in their own care. follow-up. You can see here that monitor efficacy of therapy. You really want to keep the follow-ups 2 to 4 week intervals, but it is patient dependent. There are many considerations to take into account when deciding on patient follow-up. The primary goal is to ensure the patient is safe. If there are any suggestive symptoms of major depressive disorder, suicidal ideation should be investigated. In all patient follow-up, providers should utilize the fibromyalgia questionnaire or revised questionnaire. Patient care will be individualized. It is important to consider how fibromyalgia impacts the patient across multiple domains. Prioritizing the domains to focus on will help direct and guide care. There is a revised fibromyalgia impact questionnaire, and there is a link found at the bottom of the slide that will take you to a copy. It is important for all providers to remember that patient education, evaluation, and follow-up are fundamental elements to positive patient outcomes. Individualizing a patient-specific plan of care, especially for patients who have had their run-of-the-mill or run through the system, they have low self-esteem. They may in fact require more frequent follow-up visits that provide a means of reassurance and support. Follow-up will examine the patient's quality of life, symptom control, physical conditioning improvements, provide additional opportunities for reinforcement and education, and information for the caregiver. I've included here a slide on prognosis. Approximately 50% of patients will have some sort of remission, but again, it's that daily to daily change, waxes and wanes. There is no cure, and there should be a referral made for patients who are not having any relief from treatment. Overall prognosis of fibromyalgia is uncertain, as symptoms can fluctuate. In those cases which there's failure to respond to therapy or treatment, referrals should be made to specialists including neurology, rheumatology, and or patient management. Primary care providers may want to refer to a specialized rheumatologist who has special interest in fibromyalgia or establish diagnosis. Or to establish the diagnosis if presentation is unclear. Some clinical pearls I just want to add in here, that fibromyalgia is associated with chronic headaches, irritable bowel syndrome, and they're often clues to the presence. And also that the diagnosis is unlikely in the absence of sleep disturbances or non-restorative sleep. Underlying depression should always be ruled out, and referral is done when if the diagnosis is unclear, there's poor response to therapy, and of course you refer to rheumatology, neurology, pain management, and psych for mental health consultation. In conclusion, fibromyalgia is a very complex syndrome, and as shown in this presentation, it has many challenges, not only in the presenting clinical symptoms and how they vary, but in pathology. And the pathophysiology is not fully understood and may in fact hold a psychological component and representing somatic components. Newer diagnostic tools are available but remain somewhat vague and left to subjectivity. There are no definitive lab tests for diagnosis of fibromyalgia. Fibromyalgia is not to be considered a diagnosis of exclusion. The recently published ACR 2010 criteria help providers to not be confused by all of the differential diagnoses that will be present for patients with fibromyalgia. Early diagnosis, proper treatment, coupled with a caring and well-informed physician, patients with fibromyalgia should be able to improve function and reduce pain. Appropriate care approach is one that is integrative, that incorporates a multidisciplinary approach to optimize both non-pharmaceutical treatments and pharmaceutical medications as needed. Fibromyalgia is a non-progressive disorder. However, it can hold patients captive in pain, fear, and isolation. And as providers, we need to learn to understand, validate, and reassure these patients that we are on their side and will implement an integrative approach to care. And that concludes my presentation. The next few slides you will see my discussion questions and following that references. Thank you.